Hello, my name is Caroline Ryan, and I am the Care Transitions Lead for the Administration for Community Living. The following interview is an excerpt from a recent ACL Care Transitions Peer Hour. Each Peer Hour features an interview with representatives from care transition programs in the field. These interviews focus on strategies that your colleagues are using to successfully build and strengthen transition programs, as well as adapt them during the COVID-19 pandemic to continue to meet increased needs. The goal is to share actionable information and ideas that you can bring back to your own organization. If you have any care transition questions or would like to share your organization's innovation experience, please feel free to contact the ACL Care Transitions mailbox at caretransitions@acl.hhs.gov. That's CARETRANSITIONS at acl.hhs.gov.
The COVID-19 pandemic has disrupted the post-acute care market as clinicians, the public, and family members have increased concerns of COVID-19 mortality risks in long-term care settings. As a result, there's been a growing demand for transition to community settings, particularly by hospitals and clinical leaders. As this demand for community transitions has increased, some hospitals are engaging with their local community-based organizations to develop care transition models to support expanded community transitions. Today, we will hear an excerpt from an interview that I conducted with the Multnomah County Agency on Aging, which is providing a unique care transition service model under contract with Providence Health System in the state of Oregon. And the following is an excerpt from that interview that I conducted with the Care Transitions Program Manager from the Multnomah County Area Agency on Aging, Lynn Schumer-Vallell.
So the first question is, I've had the luxury of talking with you about the great relationship that you've developed over time with Providence Health System, a very large health system in Oregon. Is actually a multi-state health system. And can you describe the evolution of the relationship between the AAA and Providence Health System?
Yes, I'm happy to do that, and hopefully you're not getting too much feedback on my end. So our Care Transitions program has been in operation since we were part of the original CMS demonstration program, which started about 2011. Our first patient in the program started in 2013, so that's when we officially kicked off our program. During that time, we were doing a lot of collaboration with the hospital partners through that CMS program. And we developed a really great relationship at one of our hospitals with a nurse inpatient manager. Her name is Nancy. And Nancy really, she loved our program. She got it. She loved the data we provided. It was a true collaboration. And when Nancy left her position at that hospital, she moved over to the Providence Health System, and she took her role as our champion with her. And she was really instrumental in us being able to pitch our program to Providence, to get in front of the right people. She was our inside advocate, and she was critical right along in step with us the entire time of getting a contract with Providence Health System in the Portland metro area. And so we've been serving patients in those hospitals for about 4 years through a contract. And our collaborative is a tri-county, tri-AAA collaborative in the Portland metro area.
I think you said a key thing there, Lynn. You said that through a contract. So you're paid for your care transition services.
Yes.
Excellent. Congratulate you on that. So are you kind of sitting back at your office waiting for referrals, or is it a kind of a more of an active process? How do you identify patients to come into your care transition program?
One of the very, very important things that we learned during the CMS pilot program that has been absolutely critical to the ongoing success of our program is that we do not wait to get referrals from hospital discharge planners, from very busy nursing staff, from those community care nurses, from anybody. We have access to the hospital's electronic medical record. We are in Epic, and we are doing our own case finding. And this is not something that we did initially. Initially, we did the thing where we were partnering with the hospitals, and we would wait. The nurses, it would set up either the nursing staff or the discharge planners. They're going to give you your referrals. And we sat, and we sat, and we sat with very, very few referrals. And then we went to our hospital partners and said, hey, we know y'all are real busy. Perhaps we could do our own case finding. And it initially started with getting a list, and then it evolved to getting the list and having Epic access so that we would get a list of potential eligible folks that met our program criteria. And then one of our coaches was in the electronic medical record in Epic, monitoring that patient and looking, when are they going to discharge? When are they going to discharge? And then getting in there just prior to their discharge so we could get that home visit set up. And now when we negotiate contracts, and this happened when we got our Providence contract, it is in the contract, it is a deal breaker. The way we pitch our program and the way our program operates is our coaches have Epic access, period.
Great. I think that's an absolute,
immensely.
I think that's an absolute best practice. So with the pandemic, we know that getting access to the hospital to do face-to-face visits and also in the home, those are sort of challenging things because of the pandemic. Have you modified your program, or you still have staff embedded actually going in the hospital and in the home, or has it been modified?
Yeah, we've had a lot of program modifications while still maintaining the fidelity of the care transition intervention that we do. We do not see the patient's bedside any longer. We're not going in and doing that hospital bedside visit. We are doing that via phone, either calling them while they're still in the hospital or calling them right when they get home. So again, our coach is monitoring when is that discharge, and so we time it just perfectly to either get them right before they discharge while they're still in hospital or calling them in the home. And they're doing that program introduction, talking to them about that program, that pitch, and then scheduling that home visit. And when I say home visit, that home visit is now a phone call. And we're also working on implementing some video conferencing options as well, but primarily right now it's a phone call. That first visit is a phone call rather than a home visit.
So that's interesting. So your team has remote access to the EMR. They're able to identify the potential candidates, enroll them, and now you're looking into also providing a teleconferencing model where you could also have eyes into the home during the pandemic virtually.
Yes, and it's been very successful. We definitely, it's always been our program model. Again, something we learned during that CMS demonstration program is doing that pitch and that sell and that kind of getting in to get the intervention and get that home visit scheduled. We take an approach of it. An opt-out version. So, hey, this is happening. It's a free benefit to you, all of those things. Let's get your date scheduled. It's kind of like asking your little kid, what do you want for a snack? You don't give them the open doorway. You give them, do you want yogurt or do you want fruit? So it's, do you want your home visit on Tuesday at 10 o'clock or Wednesday at 11:30? And that's been our approach all along. And we've been very successful in our pivots to change our model to being telephonic as well. It's a little harder to do some of the elements, some of the pillars of the Care Transitions program. Doing that med review is certainly a challenge when you're not sitting in someone's living room looking at their big shoebox full of pills. But we get it done, and we're still effective and have a really significant impact.
And I personally have done a medication review using telehealth where you're still able to see the bottles. So your move to add in the teleconferencing model is really genius because now you're able to still have the eyes into the home. So that is great. You mentioned the preset criteria. Did you work with the hospital to develop what that criteria would be for those persons you would target to get accepted to the program?
We did, and it's been pretty consistent all along from the original CMS program and then the patients that we're seeing now. But the hospital certainly had some input into the kind of their diagnosis, kind of their pain points of where they're seeing challenges with hospital readmissions. So it's a pretty set list of diagnoses, but for our fee-for-service patients that we're seeing, it's any diagnosis, it's wide open. But it's the typical, congestive heart failure, kidney failure, sepsis is on our list, that's a big one, hips and knee replacements, COPD, it's pretty standard, pneumonia. We're seeing only right now, I think it's about 6 to 10% of our patients are also COVID, were hospitalized due to COVID and are going home now. So we are seeing some folks who did test positive for COVID. Great.
So you mentioned even working with people with COVID. So have you seen that the transition needs of the population, has that changed during the pandemic? Are some people requiring additional assistance that are impacted by the pandemic?
So things that we've noticed, especially in the early days, and March was the challenging month. That was kind of the pivot month, but April and May especially, people were absolutely saying yes to the program. Now more than ever, people do not want to readmit back to the hospital. So it was a very easy sell for people to say yes to our program. Absolutely, I'm home now. I don't want to go back during this time. That's the worst place to be. So definitely we're still seeing that. Also, people are much hungrier for resources. So perhaps someone who was well-resourced on their own, they took care of their own grocery shopping and things like that. Now they're very leery about going to the grocery store and not wanting to go out. Or perhaps they were very connected to their senior center, but now that senior center is not operational. So they are very hungry for resources and supports. Also, people who had maybe family supports and neighbors coming in to visit, that might not be happening as much now because people are staying away due to the pandemic. So again, very hungry for resources. And we're a AAA and an ADRC. Who's the best position for all of those resources? We are. And that's how we pitch our program, and that is the huge value add that we have always brought to our program. And now more than ever, that is more apparent.
And it really seems as though the vision from CMS to put in the final rules that hospitals link with the ADRCs is really playing out right before our eyes in your market, where they've identified that you are the go-to resource to navigate people in the community, and that has led to a sustainable program model. So this is really great.
Yes.
So do you have recommendations for others that are beginning to talk with hospitals or starting to their negotiation? What are some key things that you would recommend? Mm-hmm. So for sure, what I talked about earlier of having access to the electronic medical record, that is critical. Though again, the way we pitch it when we've talked to new hospital partners is that's the way the program operates. So, and we have good precedent that it happens. So we've been in 3 different hospital systems had access and remote access to their electronic medical records. So that needs to happen for sure. Tracking your data, very, very important as that collaboration with the hospital partner and that sharing of data and the successes of your program. Also very important as you are doing your own internal monitoring of your program. Another good lesson from our CMS demonstration was this rapid process improvement, rapid system improvement. We use the model Plan, Do, Study, Act. We still do that, where we are constantly evaluating how are we doing our program delivery, what's working well, what could be improved. The entire team participates in this process improvement all the time, and that's just a standard operating procedure for us. And it's really proven to make us more effective and efficient in our program delivery. Also, taking the stance that, Tim, you mentioned, and I mentioned it also, that you as the AAA and or the ADRC
are uniquely positioned to provide this service. You are the expert in the community resource. So again, we're using an evidence-based care transition model, CTI, and it's that is a great model and produces great outcomes. And we bring to the table all of our resource and connections and look-see to see what else they might be eligible for. Are they getting SNAP? Have they had their SNAP reassessment? Do they need a Medicaid screening? Are they already receiving some Medicaid services? Do they need to be put into full services? All of those things, all of the community resources, the senior centers, the other evidence-based health promotion classes, a Living Well class, a Tai Chi class. You are uniquely positioned to best connect folks to that resource. And that is what typically puts us over the edge when we're talking about the program and delivery and effectiveness and the data, and then this huge thing. And we track what resources we help to connect our patients to and provide that as a data point in our report back to our hospital partners.
Great. Thank you so much, Lynn.
Yeah.
Really love the program, and it's been great hearing about it from you and able to share it. Now we're going to move on to the Oregon Network Lead Entity, which is the Oregon Wellness Network, and the director for the Oregon Wellness Network is Lavinia Gatto. Lavinia, are you there? Lavinia, if you're talking, you're on mute.
Can you hear me?
I hear you fine, Lavinia.
Great.
So, hi, Lavinia. The Oregon Wellness Network, does that represent all of the area agencies on aging across the state?
Yes, it represents all 16 AAAs. We are actually a division of the Oregon Association of Area Agencies on Aging and Disabilities. And as Lynn was saying, we're the leading voice and advocate for seniors and persons with disabilities in Oregon. Just a little bit of a profile on our AAAs is that we provide 90% of the services that the long-term services and support services that are received here in Oregon. So that we represent and we have a good pulse on what the needs are of this population.
So was there a reason that the area agencies on aging decided to form a network lead entity? Was that to support contracting in any way?
Oh, absolutely. So it started in 2017 is when we first formed, and we got our first contracting actually in 2018. And what happened is that we could see the writing on the wall. A lot of the funding for the services that we provide were starting to be reduced. So we felt like we needed to have a way to sustain those programs. So one of the major missions of the network is to find ways to sustain the evidence-based programs that we provide, like care transitions, and to do some of that centralized contracting, referrals, quality assurance, and so forth, and technical assistance for all of the AAAs.
Great. So given the great work that's happening in Multnomah County, is it in your intention to support replicating that model in other areas of the state to support members of your network to implement that model?
Yes, you hit it right, hit the nail on the head. So I think that the care transition is an example of an evidence program that's been proven to be very effective. And as Lynn said, we're in a unique position to be able to do that. So our plan is to approach, at least within the Providence system, other Providence hospitals. There are several others within the state to expand the program to those, and then also take some of the positive outcomes that they had and take them to other systems, healthcare systems and payers, and try to establish contracts with them as well.
Great. That is excellent. And so the experience from the field in Oregon really resonates in that it highlights the guidance that the U.S. Department of Health and Human Services has put out and their recommendations for discharge planning, focusing on a linkage with the ADRCs for persons that require long-term service support, and CMS guidance also recommends that discharge planners consult, and that has been brought to life in Oregon, first in Multnomah County, and then the work that Lavinia is doing with the Oregon Wellness Network to replicate that across the state. So thank you both for sharing the great experience and your great work that's happening in Oregon.
Thank you so much for listening today. We appreciate your time. We also want to thank our speakers for sharing their experiences with all of their peers on this Care Transitions Peer Hour. If you have any questions or would like any direct support from our technical assistance team, please reach out to the ACL Care Transitions email at caretransitions@acl.hhs.gov. Thank you.